All right, today I am so pleased to introduce Dr. Lingtak-Neander Chan. Dr. Chan is a professor of pharmacy in the School of Pharmacy and an interdisciplinary faculty of the graduate program in nutritional sciences at the UW. He was formerly a faculty member of the College of Pharmacy and College of Medicine at the University of Illinois at Chicago. He's a board-certified nutrition support pharmacist, an elected fellow of the American Nutrition Association, and an elected fellow of the American College of Clinical Pharmacy. His pharmacy research focus is on the absorption kinetics of micronutrients and drugs after bariatric surgery and other GI tract repairs. Other key areas of interest include micronutrient deficiencies, intestinal failure, and critical care nutrition. So you can see he's a wonderful expert to talk to us today about vitamin and supplement use in older adults. Welcome, Dr. Chan, and you're on mute.
Thank you very much, Dr. Cochran, and it's my pleasure and honor to contribute to GWEC Winter Jerry Series. And nice to meet all of you virtually. We are seeing some snow and sunshine at the same time from my office window outside Seattle campus, so it's kind of interesting. So, best venue to talk about vitamins and supplements. In the next hour, 10 minutes or so, we'll focus on 3 areas. Clearly, this is a broad topic. I have curated to 3 areas to focus on for today's discussion. We'll spend more time on more recent studies published regarding vitamin E supplementation and vitamin D supplementation. After that, we'll transition to some newer data, newer evidence regarding iron supplementation in older adults. We'll conclude with the strategy to prevent malnutrition and micronutrient deficiencies in older adults. It is always helpful to refresh ourselves on what the definition is for dietary supplement. So if we go by the legal definition, dietary supplement is defined by Congress through the Dietary Supplement Health Education Act, or DSHEA, of 1994, which is a product intended for ingestion that, among other requirements, contain a dietary ingredients intended to supplement the diet. To expand this definition, DSHEA placed supplements in a very special category under the umbrella of food. So the first thing to keep in mind is these are not medications, these are not drugs, these are under the umbrella of food regulation by the FDA. They are generally not intended to treat, diagnose, cure, or prevent diseases. And in fact, on a supplement, if there are such claims, there has to be some major backing. Otherwise, it will be considered mislabeling. Any products that are intended to treat a disease will be covered under the Federal Drug Cosmetic Act. So they will be considered as a therapeutic agent instead. Who is responsible for regulating diet supplements? It is the Food and Drug Administration. They regulate both the supplement products and the ingredients. So they have a list generated on the website describing what components can be counted towards dietary supplements. However, the FDA does not have the authority to approve dietary supplements. So anybody can create a startup, submit a document to the FDA, and then through good faith, after 30 days or so, you can start marketing the products. And FDA may come after you if there are any concerns about mislabeling, harm, or other adverse reporting. And this is an important point to remember, that the efficacy and safety and purity of dietary supplements oftentimes cannot be ensured because of the lack of preclinical or clinical trial data prior to approval. With all these legal jargon, what are the examples of dietary supplements? Well, generally speaking, it includes vitamins, minerals, herbs, botanicals, amino acid, anything that is part of our food chain, as name implies. To broaden it, some of the enzymes, microbes, such as probiotics, can also be categorized under the category of dietary supplements. One of the most important things to remember is that based on the law, dietary supplement is intended to be ingested, meaning they should be in oral formulation and only in oral formulation. No dietary supplements should be available through intravenous administration or intramuscular injection. Those should be categorized as drugs. Even a transdermal patch technically would not be covered under DSHEA. So supplements are intended to be in oral form, but that's where the varieties can come in, can be in tablets, capsules, oral powders, oral solutions, or anything that can be creative to deliver it into the gastrointestinal tract. There are also specific supplement labeling requirements mandated by the Food and Drug Administration. And for example, here's one example. There has got to be clear labeling on the serving size and direction of how to take it. There is also a clear label indicating that this is a supplement, not a drug. It would also tell you the exact ingredient of each component. So whether you're looking at a vitamin, a botanical supplement, or a combination, for example, in this case is glucosamine, chondroitin, vitamin D, and sodium. And so all the ingredients should be clearly listed. The last question to kind of lead into our discussion is, why do older adults use dietary supplements? Now, according to a study published about 10 years ago in JAMA, the majority of older adults who take dietary supplements with the goal to improve or maintain their overall health. When you look at the respondents who are women, they primarily use dietary supplement to improve bone health. Men, on the other hand, are more likely to take supplements to improve heart health or lower their cholesterol. Now, interestingly, during the pandemic, the supplement use among older adults has been increased. About 60% of older adults add supplement with the intention to boost their immune system. What supplements do they take? Here's a pretty recent study from one of my colleagues, Shelley Gray, at the School of Pharmacy. And when you look at the distribution amongst older adults, the respondents are right here, 50 years or older. Consistently, the number one choice of dietary supplements is vitamin-based products. And in fact, if you dive deeper, the number one vitamin supplement is vitamin D. So let's summarize what we have talked about so far. Because of the widespread use of dietary supplements, always ask your patient what supplement they're taking during an intake interview or history collection. Now, in fact, a lot of patients from our experience, probably mirroring your experience as well, that they may not connect the term supplements with vitamins, minerals. So specifically ask, what vitamins do you take? Do you take vitamin D supplements? This way you can clearly identify the vitamin mineral supplements if they are taking it. That may or may not alter your assessment and therapeutic decisions. Also, review the supplement products if possible with the patient, because there is no pre-approval process by the FDA. So when you look at supplements, especially combination products, the ingredients, the dose can be all over the place. So it is helpful for us to know that this patient is taking a product that contains 600 units of vitamin D rather than 4,000 units of vitamin D, which may change some of the risk and benefit assessment, as we will discuss later. With that, let's transition to our first supplement category. I'll start with vitamin E. And vitamin E supplementation has been sort of the interest and peaked probably in the early 2000s. And the interest has been fading away a little bit for a number of reasons. Recently, there has been a clinical trial published in the New England Journal of Medicine. So that's why it is really helpful to bring this back up. A lot of thought behind vitamin E supplementation is, well, it may not help a whole lot, especially in cancer prevention, but it won't hurt, right? Or there are older studies, older data suggesting that vitamin E supplementation can reduce the risk of dementia and cardiovascular diseases. So they should be helpful, right? Well, let's look at the data. Let's focus on cancer prevention. Vitamin E has been investigated as a chemopreventive agent for decades. And the paper of choice for this discussion is on bladder cancer. It is the 12th most common cancer worldwide. And up to 85% of the cases are non-muscle invasive bladder cancer. And the unfortunate part is, even after treatment, disease recurrence up to 80%. And that further triggered the interest to look into any way to prevent cancer recurrence. And that leads to our current trial, SELENA trial, which is selenium and vitamin E as adjuvant therapies for non-muscle invasive bladder cancer. Now, this is based on earlier study published in 2002, where there was an association between vitamin use and a reduced risk of bladder cancer mortality. So let's briefly overview this trial design. They enroll adults with confirmed bladder cancer, and they're randomized within 12 months upon completion of the initial cancer treatment. And then they are randomized into 4 different groups, and then they are being followed for up to 5 years for long-term clinical outcomes. The design is a 2x2 into 4 groups. So you have selenium and vitamin E, each as active ingredients. So you have an arm with selenium and placebo, vitamin E and placebo, and then selenium and vitamin E double active agent, and then you have the double placebo. The doses are selenium 200 micrograms per day and vitamin E 200 international units per day. For reference purpose, I have given you the daily recommended oral intake for both micronutrients. So you can see that the selenium intake is about 4 times higher than the daily recommended. And then the vitamin E regimen is about 8 times higher than the daily recommended intake. Now, keep in mind that these patients who have been enrolled in the study have their regular diet. So the intake is definitely on top of their regular daily intake. The primary outcome is recurrence-free interval. And if we were to jump straight to the primary finding, panel A compared the difference on recurrence-free interval with selenium. You can see that the placebo line and the selenium line pretty much overlap each other. So on the y-axis is the rate of bladder cancer recurrence. On the x-axis is time after randomization. You can see that from time 0 all the way to 5 years. So throughout the 5-year period, the incidence of bladder cancer recurrence is similar between placebo and selenium. However, if you look at the vitamin E arm, that is concerning because the recurrence rate for vitamin E is higher. Remember, this is recurrent-free. That means the disease occurrence. The vitamin E arm is associated with a higher risk of bladder cancer recurrence. What about disease progression? Once recurrent bladder cancer has been confirmed, Does vitamin E or selenium supplements suppress the progression, make the disease less invasive? And once again, when you look at the Kaplan-Meier curve, there is no difference. So we can conclude that neither selenium nor vitamin E change disease progression. However, vitamin E supplementation appears to increase the risk of cancer recurrence. And we can look at the data in a different way. Let's look at the Cox model estimates on hazard ratio. So when you compare selenium between placebo and active, the hazard ratio is 0.9 with the 95 confidence interval, including 1.0. So there's really no difference. But when you look at vitamin E between placebo and vitamin E supplementation, the hazard ratio is almost 1.5. So almost 50% higher risk. And this is statistically significant. And the incidence is not predicted by the grade, the severity of cancer, or the stage of cancer. So what is our takeaway? High-dose selenium supplement did not change or reduce the risk of disease recurrence, but vitamin E supplementation was associated with an increased risk of recurrence. What does it mean to us as clinicians? Well, vitamin E supplementation may be harmful to patients with non-muscular bladder cancer. So further study has to be conducted for safety for patients without this. So does it increase the risk of other type of cancer? Well, it may be deja vu, but we may recall that a while ago, a similar design study was conducted to look at the risk of selenium and vitamin E on prostate cancer. And this is the SELECT trial from 2009. The objective of that trial was to determine the effect of selenium and vitamin E alone or in combination on the risk of prostate cancer. Now, this is a huge clinical trial. As you can see, that there are over 35,000 patients enrolled. The regimen, in fact, was very similar to the SELENIP study we just talked about. Daily supplementation of selenium of 200 micrograms per day. Vitamin E dose was as 400 units per day, so twice the dose as selenium. The goal was to observe prostate cancer incidence over up to a 7-year period. Now, when you look at the initial analysis after 5 years, the Kaplan-Meier curve showed you that there's really no difference between the incidence of prostate cancer across all 4 arms. So, okay, vitamin E may not be helping, but it's not causing harm. As an expansion of the trial, they also look at other risk factors. So they look at lung cancer, colorectal cancer, and other primary cancer. And glancing through the hazard ratio, none of them is statistically significant, either higher or lower. So once again, neither treatment alter the incidence of cancer. And to add on other chronic diseases, if you look at diabetes, cardiovascular diseases, stroke, none of them has changed. So at best, at that point, we would conclude that selenium and vitamin E supplement didn't do anything. However, in a follow-up publication with more data points, we start to see more prostate cancer cases in the vitamin E arm. And you can see here that the 2 lines between vitamin E and placebo start to split, and the separation becomes more apparent at year 5, right there. In the selenium arm, the difference not as significant, and the combination arm is not as significant. And if we focus on vitamin E and placebo, once again, you can see that's the vitamin E arm, which is purple. The number of cases of prostate cancer all of a sudden start to spike higher after year 5. And that also translates to a change in the hazard ratio And you can see that in the 2008 analysis, it is statistically insignificant in terms of the risk. But by the time they included more data in 2011, now it is statistically significant, contributing to a higher risk of prostate cancer with vitamin E supplement. So in a way, this is deja vu. Once again, vitamin E supplementation seems to have risk, particularly for cancer. And then for completeness, there is a meta-analysis published earlier this year, I guess last year now, 2023, looking at breast cancer with vitamin E supplementation. And the simplest interpretation of the forest plot is that really vitamin E intake does not seem to modify the risk of breast cancer. It certainly does not seem to decrease the risk of breast cancer. All right, so what have we learned from these 3 trials or 3 packs of trials? Especially through SELECT, which is a 2009 trial on prostate cancer, and SELENIP, this bladder cancer trial, it is an important reminder that vitamins, trace elements are not without risks. The safety has to be carefully determined before we can recommend for general use. The assumption that supplement may not help, but it wouldn't hurt is a false narrative. Now we have 2 major trials suggesting harm with vitamin E. And we can go even further back to the CARROT and ATBC trial, where it showed vitamin A increased the risk of lung cancer. So if you have been hesitate about vitamin E supplementation in older adults, that's good because the data really supports why we should be thinking it through carefully. And if you have been recommending routine vitamin supplementation, my suggestion is to probably take a step back and rethink the safety and potential risk. Now let's transition to vitamin D. And living in Seattle, especially a day like this, there has been a tendency to think about the needs of vitamin D supplementation for bone health, prevent fall for older adults in particular, or just make us feel better because we thought that we are generally deficient in vitamin D being in the Pacific Northwest. So the common perception is routine vitamin D supplementation reduces the number of chronic illnesses, improve the outcomes of older adults, and especially effective in reducing bone loss and fall. And the narrative and the perceptions oftentimes supported or reinforced by meta-analysis. So here are 2 meta-analyses published within the last 16, 18 months. For example, low blood level of vitamin D are associated with increased major adverse cardiovascular events, but it doesn't change all-cause mortality or MI. And the other one focusing on hip fractures, and it suggests that people who have low serum vitamin D levels, especially in the older adults, are associated with higher risk of hip fracture. Now, what is important is that amongst these meta-analyses, they oftentimes included older data, and we are talking about those published before 2014 and 2015. They're mostly observational trials, and a lot of the data just focus on the plasma vitamin D concentration, but without intervention. So the real clinical trials with the intent to test the hypothesis of vitamin D supplementation really did not come in until 2015. So let's look at some of the data in the last decade, and I'll highlight 2 major trials from the last 2 years. It started with this one. This is one of the 3 earlier trials that looked at intervention. Now, this study came from Finland, which is especially important because of the high latitude. So that makes vitamin D deficiency matching where we live in the Pacific Northwest. The idea is to look at exercise versus vitamin D amongst older women and on fall prevention over a 2-year period. These are home-dwelling women between 70 and 80 years of age. They are randomized into 4 arms: placebo with exercise, vitamin D, 800 units a day without additional exercise, and then vitamin D with exercise. And here is the finding. So let's look at fall. You can see that there is no difference in fall incidence, statistically insignificant. What about injured fallers? Well, it looks like vitamin D did not change. And in fact, exercise is the most effective approach to reduce injured fall. Now, exercise with vitamin D seems to improve the efficacy further. But again, this is one of the very, very early studies suggesting that routine supplementation does not appear to change the risk of fall. And this is confirmed by other studies. For example, this one looked at even a higher doses of vitamin D. So they use a monthly regimen, 24,000, 60,000 every month, which translate to about 800 units and 2,000 units a day. And then they also have a higher range treatment arm, which is 24,000 unit plus a 25 hydroxy vitamin D3, which is usually not available in the United States. They look at exercise performance and bone density and falls. Let's focus on fall. The incidence of fall is 48% at the 800 unit per day arm, 67% in the 2,000 unit arm, 67% in the high dose arm. So if anything, higher doses of vitamin D supplementation is associated with higher incidence of fall. Now, again, this is not the first time we have seen this. We have previous trials showing that massive doses of vitamin D is associated with higher risk of falls. So again, it starts to raise the concern of empirical vitamin D supplementation. Now, one of the questions is, well, did this patient absorb vitamin D? Perhaps the fall incidence was associated with lack of absorption. And when you look at the vitamin D concentration, you can see that the higher dose arm is consistently associated with higher vitamin D level. So no, they absorb vitamin D just fine. High doses translate to higher blood level, which is connected with higher incidence of falls. And just briefly touch base on 2 other trials. This is from 2019, the VDOP trial. Once again, randomized control interventional trial, looking at 3 regimens of vitamin D, 12,000, 24,000, and 48,000 units per month, which translate to about additional 400 units a day, 800 units a day, and 1,600 units per day. The objective is to look at a change in bone mineral density. And over a 12-month period, there was no difference in bone mineral density in any of the 3 arms. And lastly, this is one of the biggest trials that we have been talking about for years, the VITAL trial, vitamin D and omega-3 fatty acid trials. And there are multiple outcomes. One of the biggest outcomes to look at major cardiovascular and cancer. And once again, supplementation of vitamin D did not change any incidence of cancer or cardiovascular outcomes. So I think it is a little better than vitamin E because at least it did not appear to increase risk. But these data really challenge the notion that routine supplementation of vitamin D is beneficial, including fall and improving bone mineral density. These thoughts leads to two studies I want to kind of highlight. They are published in the last couple of years. Let's start with the Do Health trial. And this is conducted in Europe in older adults older than 70 years of age. Observe any health events over a period of 5 years. And participants are randomized to receive vitamin D 2,000 units per day and or omega-3 fatty acid 1 gram a day and or a home exercise program, a simple home exercise program, abbreviated as SHEP. So this is basically a 2x2x2. And the primary outcome we look at right now is the incidence rate of total falls. And so let's look. The average age of the participant is 75 years, BMI is 26, and 42% have prior incidence of falls. So they're pretty comparable to our general population, in spite of being a European study. The baseline vitamin D concentration is 22.4 nanograms per milliliter. So these folks were not depleted with vitamin D to begin with. So we're enrolling folks who are not vitamin D deficient. With all these in mind, if we look at the incidence ratio on vitamin D alone, on falls, with or without vitamin D, the incidence rate ratio is 1.03. Once again, the 95% confidence interval can include 1.0. So no change. Vitamin D supplementation at this dose, 2,000 units per day, did not modify the risk of fall. Now, oftentimes when we have a negative study, we have a tendency to find trend. So the group of investigators start looking at different parameters. Would sex make a difference? Would age cutoff make a difference? Would the omega-3 fatty acid baseline concentration make a difference? Would vitamin D baseline level make a difference? Would baseline activity level make a difference? And I think it's fair to say that nothing make a difference based on the forest plot. So generally speaking, vitamin D supplementation at that regimen did not change the total incidence of fall rate. The next question is, what about just fall once, at least once? Now, we're not talking about the rate. We're just talking about the odds of falling at least once in the follow-up period. And let's focus on vitamin D. Once again, the result seems to be disappointing. No difference. Let's transition to one more study. STURDY, what a name. Study to understand fall reduction and vitamin D in you. Similar age, 70-year-old or higher, with elevated fall risk. Low vitamin D concentrations. So in the previous study, they focused on patients, individuals who were not vitamin D deficient. In this trial, they enroll people with low, but not necessarily vitamin D, because as you can see, the baseline vitamin D level is still higher than 20. So they're not deficient. The median daily vitamin D intake was 700 units to begin with. And with that, they start randomizing them to 4,000 unit, 2,000, 1,000, and 200 unit on top of the intake. And if you look at the fall incidence, doesn't matter which dose they are on, they follow the same trajectory. If you compare the 200 units and 1,000 units per day, which is the later interventional dose for another 2 years, once again, no difference with regard to the time they have the first fall incidents. And that is not the end of study, unfortunately. Multiple sub-analyses have been published in the last few months. A few things that are concerning. The higher dose arm, 1,000 unit, did not offer any benefit over the 200 units per day. And in fact, there are concern about the safety of the high-end dose because there appears to be higher risk of falling and higher risk of fracture compared with the 200 units per day regimen. So once again, lack of efficacy and then potentially harm when you use higher doses. To wrap up the vitamin section, we look at the vital ancillary study. We already visited the original vital data looking at cancer prevention, cardiovascular prevention, no difference. The ancillary study focused on frailty. Going back to the design, same patients, and we already established that there are no benefits in cardiovascular risk and cancer benefits. But did vitamin D supplementation offer benefit in reducing frailty? They used the Rockwood Frailty Index, and let's look at the results. On the y-axis, that's the frailty index ratio. So here, if the score is between 0 to 0.1 down here, it's considered low or non-frail. Between 0.1 and 0.2, considered pre-frail. Now, we should focus on the orange dots and the blue dots. The blue dots is placebo. The orange dot is vitamin D 2,000 a day. And you
Dr.
can
Chan,
see, yes.
can I just interrupt? I'm sorry, for a couple of seconds. I'm getting some questions. Specifically, did any of the study participants have osteoporosis? Do you know?
The history of osteoporosis was not quantified in the inclusion criteria.
Okay, thank you.
Thank you.
And I'm assuming that you'll sort of conclude that said, so knowing this information on vitamin D supplementation, would you not recommend dosing high doses of vitamin D in patients who have low vitamin D levels? So if you wouldn't mind kind of keeping that in mind as you finish this up, and can just, maybe you're planning to have that sort of summary.
Yes, absolutely. We will
Okay.
have a summary slides down the
Great.
road.
Okay, thanks.
Yep, you're welcome. So back to here to compare the placebo arm blue versus the vitamin D arm. Now, if there is any benefit of vitamin D to reduce the incidence of frailty, you would see the change in the frailty score. And you can see that at any timeline, the scores are comparable. Once again, no effect on vitamin D. And in fact, to make it more interesting, what if we separate the data based on vitamin D level? So up here is the group with lower vitamin D level, lower than 20 at baseline. And that makes sense that their frailty score is higher than those patients with higher vitamin D level. However, vitamin D supplementation, once again, failed to change their risk in becoming frail, regardless of the baseline vitamin D levels. So the last slide before we do a summary. So thank you for going ahead a little bit. Once again, you can see that the two lines between vitamin D and placebo completely overlap each other. And the forest plot, once again, show no difference. All right, so what's the takeaway? Do Health is one of many RCTs in the last decade showing that routine vitamin D supplementation in reducing falls and fractures does not seem to pose any benefits. Now, if we dig much deeper to all the study, there is a benefit in supplementing vitamin D and risk reduction for those with vitamin D deficiency. However, this benefit is not observed in patients with vitamin D higher than 20. And this has been very, very consistent across the board in most of the RCTs published in the recent trials. And then higher doses may increase the short-term fall risk. And that's really the challenging question. What is higher doses? If we look at study, the concern may begin at 1,000 units a day. So perhaps the daily supplementation should not be more than 1,000 units a day, unless your patient has severe vitamin D deficiency. Then the priority is to improve their vitamin D status first. But once they reach 20 as a threshold, we may want to rethink our vitamin D regimen. And to kind of wrap up our big discussion in this area, I can use the United States Preventive Service Task Force recommendation. This is published in 2002. And they look at a number of micronutrients, but if you look at vitamin D and vitamin E, did not change all-cause mortality, cardiovascular, and cancer risk. We can add that in non-vitamin D deficient patients, the benefit in reducing fall may be minimal. And then vitamin E clearly did not modify cancer risk and may increase the risk for bladder and prostate cancer. So I want to summarize it with 2 points. Routine supplementation. And again, this is the key word, routine supplementation. We're not talking about treating deficiency. That's what we should do. But routine supplementation is not warranted. Our primary goal is to make sure the patient intake of these micronutrients, particularly for vitamin D and vitamin E, is minimally meeting the recommended daily allowance and prevents deficiency. Now, for high-risk patients who may develop deficiency, history of bariatric surgery, decreased oral intake, chronic GI problems, history of fracture, then we may want to look at individual factors and make a individualized decision. But again, general population-based supplementation does not appear to translate to clinical benefits. So I'm going to take a 15 seconds break so you can put down any questions you may have before we transition to the next objective. I know we have been talking about some pretty dense clinical data. So give some seconds.
Well, that's helpful because we have gotten a couple of questions through the chat and the Q&A. Are there other studies that have been done with vitamin D not related to falls, like studies in the immune system?
Yes, the answer is there have been quite a few interventional trials looking at different clinical outcomes from depression to cognitive functions. Again, the clinical outcomes seems to be all over the place for well-designed RCT. And so we really don't have a lot of consistent conclusion.
And another point was made about low vitamin D levels, that there are MS concerns. It's thought that MS can be caused due to low vitamin D levels. Do you have thoughts on that? Tamara was asking.
And that is a very fair question. Patients with multiple sclerosis is perhaps in a separate category. Now, in most of these clinical trials, MS or MS risk is not part of the exclusion criteria. So I think we have to look at multiple sclerosis as a slightly different category than the rest of the older adult population who may not have the same disease states.
And I think the only other thing to mention is just that Mary Zeitner said she saw this title in a newsletter, How Vitamin D Influences Young Onset Dementia. Do you have any awareness of research in that area?
I'm not sure which study you refer to. I'm happy to talk to you after the program and look at the data together. For the purpose of this presentation, I want to focus on bone health and fall risk because that has been really the push, at least from my interaction with a lot of patients and clinicians, that because this is something we have been strongly believing in, right? Vitamin D is good for bone health and prevent risk. And this seems to be in doubt from really, really well-controlled clinical trials.
And Carolyn poses the question that we deal with a lot in terms of discussions about vitamins and supplements and that sort of thing. She said, yikes, so who are these influencers of taking supplements, and why are so many providers casually recommending vitamin supplementation with a patient who does not have subadequate levels? And I'm wondering if you might want to just give the usual, we focus on the research kind of thing.
Yeah, that is a fair statement. Part of our responsibility is to look at the data, high quality clinical trials. And yes, theoretically, going way back from animal studies, in vitro studies, theoretical mechanistic description, these are all great ideas. As clinicians, we believe in how this translates to patient outcomes. And the bad news is we have not had high quality interventional trials until in the last couple of decades. The better news is these high quality clinical trials give us an opportunity to rethink and proceed with caution. So there is clearly a lot more we have to learn down the road. But I think at this point, the main takeaway point is let's not assume that even if they don't work, they would not cause harm. I think this should be a real takeaway for vitamin E.
That's very helpful. And I don't have any more questions, so take it away.
Thank you. So let's transition to a slightly different supplement, iron. And why do we talk about iron? Well, you may not believe it, that iron and anemia is one of the most common disease states in the world. And shown here is the incidence of anemia across lifespan. Now, let's focus on two lines. You look at the blue lines, these are incidence for male. You can see that across lifespan, the risk and incidence of anemia for men goes up with higher age. Now, the bar gets shorter because the population gets smaller, but the incidence is actually getting higher. For women, the red line, it makes sense that during childbearing age, incidence of anemia is very high, but that does not seem to decline significantly amongst older women. So this is indeed a disease state that affects our older adults. What is the most common cause of anemia? This is a world global prevalence data. So you can see there are all kinds of causes, but one thing that is consistent is that orange is always the longest bar at every data point, and orange represents iron deficiency. And this includes our older adult patients. So once again, iron deficiency anemia is an important clinical condition for us to take into consideration. There are potentially many causes, and at this point, my goal is not to focus on the causes, but focus on supplement, because there are new studies to re-explore a better approach to treat iron deficiency. Why do we care about it? Well, a few things to take into consideration. We know, either from personal experience or patient's experience, that oral iron is nasty. It gives you all kinds of complications, GI side effects. It is not covered by insurance. So is an out-of-pocket expenses that can be costly. And between the side effect and the cost, oftentimes it leads to non-adherence. Not with oral, but IV iron can lead to iron overload. So there are clearly risks with iron supplementation. Historically, when you look at textbook, and I start to see clinicians doing it differently, which I'm very pleased because we have been talking about this for quite some time. But historically, the iron supplement regimen is iron 325 milligrams 3 times a day. There is no clinical data to justify this regimen. This is all calculated based on physiological modeling, and this is the model, assuming that for every 100 cc of blood, it contains 0.2 grams of hemoglobin. And then we assume that every 1 gram of hemoglobin contains 3.4 milligrams of iron. And therefore, we will be carrying that much elemental iron in the blood. And we also assume that the bioavailability of oral iron is a constant of 20%, which is not. In iron deficient state, bioavailability is up to 60%. In a person who is iron sufficient, bioavailability is lower than 10%. But with all these assumptions put together, the model would suggest that taking iron sulfate, 325 milligrams, 3 times a day, would give you adequate amount of elemental iron to fit this model. So this is based on old physiology. Now, let's add some new physiology into the picture. How is iron absorbed? There are 2 types of iron, heme iron from myoglobin and hemoglobin, depending on the diet. And then for the most part, the iron supplement is from non-heme iron, ferrous sulfate, ferrous gluconate. The primary site of absorption is in the duodenum through specific transport protein, which is saturable. Any unabsorbed iron from the duodenum may pass further down. The colon has a little bit of capacity to absorb iron, and that's especially the case for patients with bowel resection. For non-heme iron, the absorption varies depending on iron study, iron adequacy. Going back to the left side, look at the diagram, right? Most of our dietary iron comes in as a 3+ ferric form. Ferric iron cannot be absorbed into the enterocytes. It has to be converted by ferroreductase to ferrous, 2+. And then it can be absorbed into the cell, and then it's being processed, and then eventually being released into the bloodstream for us to use. Oral iron supplement, ferrous sulfate, for example, is in 2+ form, so they are readily absorbable. The other regulating function is down here. Once iron enters the enterocytes, it has to be released. And our body is so smart that it has a unique mechanism to make sure that we will not have too much iron from our diet that lead to iron overload. And the process is regulated by an enzyme called hepcidin. Hepcidin is a hepatic enzyme that regulates ferroportin, which determines how much absorbed iron can actually be released into the systemic circulation. It appears that if we are iron deficient, hepcidin level will go down and then allow more iron to pass through. But if we have plenty of iron on board, hepcidin level would go up, and that basically work as a door to block ferroportin channel. But there are other factors that would raise hepcidin concentration, inflammation. Any type of inflammatory response would raise hepcidin, which will limit how much iron that can be released into the systemic circulation. And in fact, this is likely the mechanism that we refer to as anemia with chronic disease. Now, what's more interesting now we have learned is that when you take a single dose of oral iron, it gets absorbed if you are iron deficient. Serum ferritin, the storage form of iron, will go up. Transferrin saturation, the protein that carry iron around, would go up. They're happy, I need iron, so I'm going to take them. But that process will immediately induce the release of hepcidin, which may in turn make your next oral iron dose less absorbed to protect the body. And then some data suggest that any unabsorbed iron from the GI tract will then pass on down to the colon, which then impair the colonic microbiota. And that may be the contribution to constipation, diarrhea, or other GI side effects. So that makes us question, well, maybe there is room for us to refine our iron regimen. And that leads to a series of studies starting back in 2015. The idea is to compare once a day and twice a day oral iron supplementation. So the once daily regimen is 60 milligrams of elemental iron once a day. And then the twice daily is 60 milligrams of elemental iron twice a day, given at 8 a.m. and 4 p.m. Let's look at the data. For once daily dosing, about 23% of the iron dose is absorbed at the first dose. 24 hours later, the second dose, the absorption goes down by 8%. Why? It is due to the corresponding increase in hepcidin. So the body starts to recognize that, whoa, you have a big boost in iron. Let's slow this process down so that it wouldn't translate to harm. Now let's look at the twice daily dosing. The first dose gives you 17% absorption. The next dose, which is only about 8 hours later, the absorption goes way down from 17 to 2. And then the third dose, which is 22 hours later, the absorption is now down to 9%. So it implies that the more frequent you give it, for each subsequent dose, you absorb less and less. And this is due to the spike in hepcidin. So let's summarize. Multiple daily doses of oral iron is associated with a progressive decline in iron bioavailability. And this downward trend is due to an increase in plasma hepcidin. The body figured out that this is not normal. Our diet would not give us 65 milligrams of elemental iron. We have to block it. So by giving twice a day or even 3 times a day, we are actually absorbing less iron compared with once a day. And worse, the non-absorbed iron would stay in the GI tract, causing GI side effects. Now, how can we get around it? Transferrin saturation peaks for 4 hours. Hepcidin peaks for 8 hours, peaks at 8 hours, and stay high for about 24 hours. And that corresponds to the thought that, well, maybe giving once a day every 24 hours, you may lead to a cycling, right? So hepcidin spikes, and then it starts to decline in 24 hours, and it may be a good time to redose it. Now, what if we extend the interval? What if we give it every other day? That would allow hepcidin to drop more, and perhaps allow the next dose of iron absorb better. That leads to the study to look at alternate day versus consecutive day. So this is 60 milligrams of elemental iron per day versus 60 milligrams of elemental iron every other day. And when you look at the bioavailability, the every other day regimen after 7 doses, which is 14 days, because it's given every other day, give you 5% more iron absorbed into the body. And that translates to more elemental iron. A 7-day regimen given daily give you 131 milligram of iron in the body. Every other day for 14 days, 7 doses, give you a total of 175 milligrams absorbed into the body. So it's actually more efficient. Now, how do they determine? They use a tracer, so they know exactly how much came from the pill. Improved absorption is a good thing. More importantly, when you look at the alternate day dosing, the incidence of GI side effect goes down. So that really mapped up with our expectation. That's the non-absorbed iron is the primary contributing factor to GI side effects, which is oftentimes the cause of discontinuation of treatment. So the alternate date approach not only may enhance absorption, but also decrease the incidence of GI side effects. Now, one of the challenges is that these initial studies focus on patients with iron deficiency without anemia. The question is the finding the same if a patient has anemia? And here is the follow-up study. We have 2 groups. So BD is twice daily and alternate day every other day. The baseline hemoglobin is 8.9 grams per deciliter. And so they are definitely anemic. When you look at the rate of increase in hemoglobin concentration between the 2 arms, in patients with documented anemia, it seems like the twice daily regimen would improve hemoglobin a little faster, but not necessarily significantly faster. And in fact, the alternate day eventually caught up. Now, here you can see that the p-value is 0.02, but I would argue that a hemoglobin concentration of 12.0 and 11.7 is clinically not significant. What about adverse events? If you look at the adverse events, well, no surprise. Alternate dates give you less nausea compared with twice daily dosing. So multiple times per day regimen of oral supplement of iron should be discouraged at this point. What I would recommend is once daily is okay. Every other day may be confusing, may be difficult to manage. So once daily is probably a reasonable place to start. Twice daily, for patients with anemia, maybe. We still have to learn more about it. But definitely not going with 3 times a day, because now we have an established mechanism to explain why it simply doesn't do any better, but increase adverse events. So once a day or every other day. Now, the downside is the duration of treatment for iron deficiency or iron deficiency anemia may have to be extended. And we want to make sure to monitor hemoglobin concentration and serum ferritin. We want to fully replenish iron storage. Now, with that, another common approach is, well, let's make sure you take oral iron with vitamin C. Does it really matter? Finally, we have a randomized control trial to look at that in 2020. They look at oral iron supplement with or without vitamin C. And when you look at the change in hemoglobin concentration, with or without vitamin C makes no difference. So in 2 weeks, the change in hemoglobin concentration is 2 grams per deciliter with vitamin C. Without vitamin C is 1.8. In 8 weeks, the total change in hemoglobin is 4.2 grams per deciliter with vitamin C. Without vitamin C is 4.1. Really no difference. And you may ask, why isn't there a difference? That goes back to the diagram I show you. Remember, most non-heme iron exists in the 2+ state, ferrous state, which is readily absorbable through the channel. Dietary iron, pardon me, is in the 3+ state. So by giving vitamin C, you actually help convert the 3+ to 2+ and stay there to maximize absorption. And that's consistent with a lot of the dietary interventional trials. By having vitamin C on board, you tend to absorb more dietary-based iron, but it doesn't seem to change ferrous supplements. Why does it matter? Well, it matters because it can reduce pill burden for our patients. If taking vitamin C doesn't really change how much iron being absorbed, but increase pill burden or cost, why do we do that? I think it's fair to say that in this case, vitamin C may not help, but at least it doesn't show any harm. So just a little break, and we'll wrap up the iron on really new finding. Iron deficiency anemia in heart failure. The prevalence of iron deficiency is about 50% amongst patients with symptomatic heart failure. Now, I put an asterisk there because it all depends on how you define it. This is a very new document from the Heart Failure Society of America. Why does it matter? Well, because the two guidelines published, this is a European guideline in 2021, and then this is the 2023 guidelines, now suggest that iron supplementation for patients with heart failure. How does that happen? They define iron deficiency in heart failure using these criteria: serum ferritin lower than 100 milligram per deciliter, or between 100 and 299 with a T-sat lower than 30. Now, this is borrowed from renal literature. The idea is in patients with heart failure, by boosting their hemoglobin function, by boosting iron, which serves as multiple function, including electron transport chain, mitochondria function, that may help improve clinical outcomes. And they have used this criteria to conduct a series of clinical trials. And what they have found is that by giving iron in patients with heart failure, fulfilling these criteria, as we have just talked about, meaning if you're a patient with heart failure with a T-sat of 15 and ferritin of 120, by giving you iron, multiple studies have suggested that there's an improvement in functional performance, decrease in the New York Heart Association functional class, so you actually go from class 3 to class 2, improved quality of life, decreased number of hospitalization. Now, there are some contradictory findings, but there are really big trials that kind of support that. So I suspect that many of your practice may involve patients who work with their cardiologist starting to make referral. Now, I do want to emphasize that most of these trials utilize ferric carboxy maltose. So it is IV iron, not oral iron. There are limitations despite this guideline recommendation. We don't know what dose to use. When you review those clinical trials, the doses of ferric carboxy maltose was all over the map. Number 2, so we really don't know the best regimen. Number 2, IV iron products are not interchangeable. So the dosing for one IV iron product is not equivalent to another iron products because of the characteristics of the formulation. The other thing I have to really emphasize, and that's my personal concern, is that all of these studies showing reduced hospitalization, improved quality of life, have a follow-up term of 52 weeks, 1 year. I'm more concerned about raising the total body iron in the long run. Would that translate to any long-term risks? So I would really, really like to see more long-term data. But again, because this has been well discussed and now incorporated into the heart failure guidelines, you may start seeing this practice, especially through the collaborating cardiologists. You may ask, would oral iron work? Well, there were 2 studies showing oral iron did not meet the same benefit. But I do have a criticism of the design because they use the 2 and 3 times a day regimen. And we have just talked about how multiple times a day translate to decrease absorption. So it will be interesting to see an oral supplementation study with every other day dosing. And for completeness, I have listed the currently approved, FDA-approved IV iron products, and you can see that they are not interchangeable because the administration regimen is different. Their amount of elemental iron per dose is different. So let's summarize. Iron deficiency is pretty common around older adults, and when treating iron deficiency, start with daily or every other day, but not 2, and definitely I would not recommend 3 times a day. Co-administration of oral iron, especially ferrous salt with vitamin C, is not as critical as what we have thought. And also, you may start seeing older adults receiving IV iron therapy. So that may be the reason they get iron even without anemia. May want to keep an eye on any long-term risk associated with iron overload. Again, I will pause for 15-20 seconds and we'll wrap up in the next block. And next block is a much shorter version, so we will be able to end on time.
Dr. Chan, this has been really helpful. Few questions have come across. What are your thoughts on iron supplementation with low serum iron, even ferritin? Let's see, I'm not reading this right, just a minute. What are your thoughts on iron supplementation with low serum iron, even if ferritin and hemoglobin and hematocrit are within normal range? You've kind of answered it, but
yeah, so there are two ways to assess it. If you have iron deficiency anemia, there is no doubt iron supplementation is clearly indicated. An important laboratory parameter to keep in mind is as we replace iron, hemoglobin improved, we want to make sure that ferritin is also improved because that represents or that reflects the total body iron storage. Now, I think one question oftentimes come up is which iron test do we look at? Serum iron, ferritin, or TSAT? Serum iron is the least sensitive laboratory test because inflammation would mobilize iron, and that would lead to a transient fluctuation of serum iron concentration. So the better test result is probably ferritin. But we also know that ferritin can be mobilized through iron trafficking. And so now there is start to have the thought that we may want to focus on TSAT. But to sum up, the 2 tests most relevant on iron status in the body is TSAT and ferritin.
helpful, very helpful. Thank you.
Thank you.
Another question, has OTC extended release once daily iron been compared or otherwise looked at?
Yes, some of the studies use extended release. So the extended release doesn't really change how hepcidin behave because remember, hepcidin is being triggered once we absorb iron, and hepcidin stays elevated for at least 24 hours. The sustained release oral iron product would deliver the iron in about 6 to 8 hours. So this is still within the time period with elevated hepcidin. So that wouldn't, whether you give immediate release oral iron or extended release iron, it wouldn't change the body's hepcidin response. So what we just described still applies.
Okay. And related to your last study that you mentioned about heart failure, for IV iron in heart failure, did the RCTs include patients with, I'm not going to have I don't know how to pronounce it, HFpEF or?
Oh, most of the studies enroll patients with heart failure with reduced rejection fraction. So
Okay.
patients with preserved rejection fraction, this is usually not the case. So you are much less likely to see IV iron administered because the trials focus on patients with heart failure with reduced rejection fraction. And in most of the trials, the threshold for ejection fraction is 50% or lower.
Thank you so much. I'm so embarrassed, but I'm not familiar with how to read that terminology. So
it's a mouthful.
yeah. And then just a basic question: does eating chicken liver give the iron that we need?
Any animal, well, I guess only animals have liver, right? Plants don't have liver. What am I talking about? It's late. I think any liver would provide iron. The iron source would be heme iron mostly. So the regulation of heme iron is slightly different from the non-heme iron. So yes, for a patient of yours, if the diet can involve organ meat, that would be a source of iron that can improve iron status. What we describe in terms of regulation may not apply because the process of the body recognizing heme iron is slightly different.
Okay, and that's all the questions. Thank you so much.
Thank you. And I'm going to spend the next 5 minutes to finish this last bullet, and we should have a few more time to address questions. So
Great.
we'll focus on the strategy to prevent malnutrition. Being a nutrition support practice, preventing and treating malnutrition is definitely one of my passion, and especially thinking about older adults who are scheduled to surgery, and now we are performing surgeries such as cabbages, valve replacement at much higher age. And we have very, very limited data on their clinical outcomes with regard to other malnutrition risk. So in a way, this is a call for collaboration and opportunity. If you have any idea that we can work together to improve the clinical outcomes of our older adult patients going through surgery, I would be really, really interested in collaborating. Slightly going back to frailty we have talked about, right? Frailty comes with sort of a circle of threat. For patients who are frail, oftentimes start with malnutrition, and that leads to weight loss. Weight loss leads to loss of muscle, sarcopenia, decreased activities, losing more muscle mass, and now you are not able to move around as well. You have increased risk of other complications, and that may further drive malnutrition. So this is a vicious cycle that is tightly connecting malnutrition and many other geriatric syndromes. Do we know the prevalence of malnutrition in older adults? We do have limited data. If you look at community dwelling adults, about 3%. Now, this depends on your definition of malnutrition, which is a separate topic. But when you start looking at home care services, this number goes up. And then when you start looking at those who are hospitalized, now we're talking about 1 in 4 or even more adults will fulfill the criteria of malnutrition. And then in addition to those who already fulfill the criteria of malnutrition, 1 in 4 adults in the community dwelling are at risk for malnutrition. If you look at sarcopenia alone, loss of muscle mass with aging, the incidence is 10 to 20% amongst all our older adults with 60 years or older. And the presence of sarcopenia predicts falls, cognitive impairment, frailty. So these are really important predictors. And if we can prevent, delay, or even reverse sarcopenia, malnutrition, we are indirectly having an impact to decrease frailty. And there are high-risk groups that have been identified. Women are at higher risk of developing malnutrition and frailty compared with men. And then rural populations, probably due to the access to health care, and then age, and those with multiple chronic diseases. Generally speaking, what are some factors that would predispose to malnutrition? And I am confident that many of you already are quite familiar and aware of that. That starts with eating, appetite, the needs for others to help out feeding, and oral health problem, dental procedures, dry mouth from medication, adverse drug reaction, anticholinergic agent, dry mouth from radiation therapy of head and neck cancer. That would lead to difficulty in eating, malnutrition risk. Dysphagia, again, head and neck cancer, difficulty in swallowing, dry mouth. Then now there are other components, and make sure we don't forget that obesity is indeed a form of malnutrition. And in fact, studies looking at obese patients, including obese older adult, with increased fat mass, they have lower muscle mass. So sarcopenia is oftentimes present in obese patients or patients with obesity. Other risk factors are pretty much self-explanatory, right? If you have chronic GI problem, constipation, diarrhea, pain, cramps, bloating, that would affect appetite and diet. Then now you have the mentation in access to food, food insecurity. This is a whole separate topic we can discuss. Experience in life, loss of a spouse, change in living environment, loss of independence because of vision problem, loss of a pet. All these triggers significant emotional changes which may affect eating problem. And they can be compounded by other chronic health, oral dentition problems. And then, of course, being a pharmacist, I must emphasize that polypharmacy, adverse drug reaction, and drug-nutrient interactions all add to it. So there are so many ways for us to screen and try to prevent malnutrition. And going back to frailty, interestingly, this study from Spain showed that anemia is a predictor of frailty. So again, it ties back to the significance of iron deficiency, anemia, malnutrition, and frailty. And we have a couple of slides to finish. I want to wrap it up with patients, older adults with heart failure. If they present to the ED because of heart failure exacerbation, does malnutrition modify their clinical outcomes? 65 years and older? The simple answer is yes, because in older adults with heart failure, if malnutrition is present, the hospital admission rate is increased by about 15 to 20%. The presence of malnutrition would also increase mortality rate in 30 days, 5 times higher. So really, malnutrition is a significant burden on the clinical outcomes of our older patients. So what can be done? What kind of action can be done as we conclude this seminar? Start with the basic. Again, let's not worry about empirical vitamin E, vitamin D supplementation. There are a lot of debates on benefit and risk, but let's make sure that they are meeting the daily recommended intake. And this is particularly important for patients with food insecurity or decreased oral intake because of other factors. And if they have decreased oral intake, if they have food insecurity, this is when supplementation of vitamins and trace mineral may be helpful, because your goal is to bring them to this daily requirement. Also keep in mind that some vitamin requirements for older adults may be higher than younger patients. So look for the diet component, check their vitamin supplements content. If an older 85-year-old adult is taking a vitamin supplement that contains vitamin B6 below the intake limit, and we may want to work with the patient to modify, change to different products. We already talked about the significance of anemia and drug-nutrient interactions. So hopefully this is a relatively generic but achievable action plan as a first step to prevent malnutrition in older adults. So let's summarize in the next 30 seconds. Empirical vitamin supplementation can cause harm in some individuals. In vitamin E in particular is really the vitamin of concern. And unless we have documented deficiency, at this point, I do not recommend empirical supplementation for everybody. Vitamin D supplementation is helpful in patients who have deficiency. Beyond that, it remains debated. And I think the overwhelming favorable effect in preventing fall, now we may have to approach it with a little bit of skepticism. Iron deficiency is fairly common among older adults, so screen for it, replace it, and because especially it predicts frailty. And then when we treat iron deficiency, start with once daily, if not every other day, and avoid multiple daily. It would decrease the efficiency and increase adverse reaction. And lastly, malnutrition negatively affects hospital course, surgical recovery, and outcomes of our older adults. So this is particularly one thing we can do when they're in the community, because oftentimes by the time they have unexpected hospitalization and they are not in good nutritional state, that is not a good setup for surgery. So I'm going to stop here. I want to thank Dr. Cochran again for this opportunity to share some of my thoughts with you. And please feel free to reach out to me if you have any additional question. You have my email address. And I will stay on and happy to answer any questions if you want to stay on. And Bob, I'm going to turn back to you. Thank you.
Oh, thank you. This was absolutely excellent. And if you see the chat, which I can share with you later, just a lot of kudos and thanks, and several people saying we should have a whole series on micronutrients, supplements, vitamins. It would just be really helpful. So I don't have any other questions that have come across, but we can hang on there for a few minutes, and just really appreciate it. Just excellent. I appreciated the summaries that you had, very practical, and yet I also appreciate the research base. Great, and we will see everybody next week. Thank you, Dr. Chan.
Thank you very much. And everybody has a safe trip home, and stay warm.
Yes, stay warm, that's for sure. Okay.